All right. Thanks to everyone for joining in. Thank you, Casey, for putting this together, the introduction. So as Casey said, my name is Dan Davis. I'm a shoulder and elbow surgeon here at the Rothman Institute. I'm going to talk today about rotator cuff injuries. And a common question I get when I tell people that they might have a rotator cuff injury is, aren't those just for pitchers? And we'll give away the quick answer initially that it's no. So I'm just give you guys a little background if you haven't been in to see me, or a little bit about myself. So I grew up in Pennsylvania, the northeast part of the state, Wilkes-Barre, Scranton area. When I later in high school traded the view of those mountains for some mountains in the Caribbean, I actually graduated from high school in St. Thomas. I went from there up to college in North Carolina at Wake Forest. And then continued my trek south to Tulane, where I did a master's in human genetics as well as my medical school training. Then came back to Pennsylvania. I did my residency at Jefferson along with the Rothman physicians, as well as my fellowship here at Rothman in shoulder and elbow surgery, and then have been working here since 2017. And as Casey mentioned, I practice in the northern suburb area around Abington, Willow Grove, and see patients in Bluebell. I operate at Abington Hospital and a surgery center in Bluebell. Along all that time, I managed to have this lovely family. So my wife is OBGYN at Christiana, and then these are our two girls, Maddie and Nora, that certainly keep us busy. So the goals of today's talk are to go over the anatomy and function of the rotator cuff, what exactly that is, why it's important for the function of our shoulder, review what I do when I see a patient that really with any shoulder complaint, and how we kind of narrow that down to being a rotator cuff type of complaint. And then I'm going to go through some of the natural history of rotator cuff disease and how I go through decision making for what to do for patients. I'm really going to get into some of the weeds in terms of what we look at in research in rotator cuff injuries and repair, and how that plays into my decision making and counseling on patients and what to do for their shoulder. So again, the short story is rotator cuff injuries are not just for pitchers. So here's the basic anatomy of the shoulder. So the images you see on the left are the bony aspects of the shoulder. So you have the scapula, which is your shoulder blade. The outside part of the scapula, we call the glenoid, that's the socket of the ball and socket joint of the shoulder. There are these other prominences around the scapula as well that play into the shoulder joint, as well as the clavicle or the collarbone. And then the ball part of the ball and socket comes from your arm bone, which is your humerus, and that makes up that ball and socket joint. As you'll notice, and I tell a lot of people, the socket, the glenoid, is very shallow. A lot of times we refer to this joint as like a golf ball on a tee. And that gives us a lot of range of motion in the shoulder, but it relies on stability from soft tissues, the most important of which, from a muscular standpoint, is the rotator cuff. So the rotator cuff is a group of 4 muscles that start from the shoulder blade and they attach onto that ball part of the humerus. The subscapularis is the one in front. The supraspinatus is the one up top, most commonly injured. The infraspinatus and the teres minor come around from the back and pull around the back of that structure. And so the way that this works is it creates this whole cuff around your shoulder. And not only do they help with moving the arm around, but really the biggest function is this concept we call concavity compression. So there's the concavity of the glenoid, and then the humerus, that ball, is compressed into the glenoid by the rotator cuff muscles pulling it in. So when people have rotator cuff injuries and then have trouble raising their arm up, it's not so much that the muscle that's injured is causing the shoulder to be weak. It's that the muscle that's injured is not allowing the ball to stay stable in the socket anymore. And as the other bigger muscles around the shoulder try and raise your arm up, that humerus, that ball, is riding up and down on the socket, and you don't have, as I say, a stable fulcrum to raise your arm, because you need to have a good stable fulcrum. Otherwise, it's just going to go up and your arm's going to feel uncomfortable and it's going to make it weak. So that's what happens when you have a rotator cuff tear. And this is a depiction of what that might look like, where that supraspinatus muscle, or tendon rather, attached where it attaches on the bone, can be torn. And that can throw off that concavity compression. So there's two ways in general that this can happen, either acute or chronic. So acute is somebody who has an injury, a fall, something happens, and then all of a sudden they just can't raise their arm anymore. They get a lot of pain down along the side of the shoulder. Not always consistent in terms of the pain, but certainly if it's a big enough tear, they can have a lot of weakness. This can also happen after a shoulder dislocation. And then there are the chronic tears, and these are definitely more common in what we see. These are the wear and tear type of patterns. And we'll go into a lot of the data a little bit later, but this is more common, and it seems to be a structure that just wasn't totally designed to last a lifetime, or at least the amount of active lifetimes that we're living now, where that repetitive overhead motion and doing things with the arm does start to wear out the tendon to where it starts to fray and then eventually tear. This can be something that's a more slow developing pain. A lot of times, even if people have a full tear, they might be able to maintain good function of their arm. And this is because as the tendon slowly tears, the other muscles of the rotator cuff and the other muscles around the shoulder help to compensate for that loss of function of the rotator cuff. However, people might notice that they all of a sudden start having more difficulty with overhead motion with any sort of strength because they're not having that good concavity compression holding it together. So how does this tear, how do these chronic tears work? Historically, when these were first described by some of who we consider the giants of doctors of shoulder surgery, there's some names here: Dr. Neer, Dr. Bigliani. These are people that we really look up to, who help define a lot of what we do in shoulder surgery. And when they were talking about rotator cuff injuries, there was a lot of thought that it had to do with extrinsic, meaning not within the tendon itself, but all the other structures around it that were wearing out the tendon. And you've probably heard of people talk about impingement syndrome, which is something that was described by Dr. Bigliani. And the thought there is that those other bones that I showed in the picture of the scapula, as your shoulder goes up and down, the rotator cuff tendon gets pinched between the bones, and over time, that tendon can wear out and tear. And while there probably is some aspect to that that's true, we've also, in more research, noticed that the rotator cuff tendon doesn't have the best blood supply. The cellular makeup of the tendon changes as we get older. Where the tendon attaches to the bone, the cellular makeup there also changes as we get older. There's increased things called reactive oxygen species. These are when molecules in the tendon start to break down and they make the tendon weaker. So in other words, there's a lot of molecular factors that are involved with time where the tendon starts to wear out. So really, in all honesty, it's a matter of the two interplaying together that causes the tendon to wear out with time. So when I see a patient in the office, what are we looking for when they come in with usually a rotator cuff problem? Generally, people are talking about pain along the side of the shoulder, which does confuse people too. They say they have arm pain. I said, it's some from your shoulder. And then they said, no, it's not my shoulder, it's down here in my arm. And really that pain radiates down underneath that big deltoid muscle. And that's pretty common for rotator cuff injuries. So I always want to know the age of the patient, what they do for work, how long this has been bothering them, where the pain bothers them. Is it just pain, or is it a functional deficit too? Is there difficulty with motion overhead? Do they feel weak? Can they raise their arm by itself, but if you put any resistance in it, you have more pain and difficulty raising it up overhead? So these are all a big part of me trying to figure out what the biggest complaint is and what we can do to treat that. Then you move into the physical exam. I will have you always examine both sides, especially the first time I'm seeing somebody, so that I can compare what a normal shoulder is compared to the one that's bothering the patient. So we'll look at range of motion, both active and passive, meaning active, you're moving it under your own power, passive, meaning me moving it, to see if there's any difference between the two. Strength testing, specific strength tests of the rotator cuff muscles, as well as some other special tests, potentially if there's any stiffness to the shoulder or if there's uh, anything on history or exam that suggests a labral injury or a biceps injury. I always want to look at all these factors that are related to shoulder problems. I usually always get x-rays, especially for a first visit, somebody that has new pain or ongoing pain. We definitely want to rule out that there's not a bony problem. And even though most rotator cuff problems are soft tissue based, there are some giveaways on x-rays that we can get even before we get into more advanced imaging. So some things you'll note here, see the ball lined up in the socket. On this view on the left, you can see the ball is actually sitting on the higher end of the socket, which can be a suggestion that there's a rotator cuff tear, because again, if that rotator cuff muscle or rotator cuff isn't fully intact, you can have what we call superior migration, meaning the ball moves up, which is superior. This x-ray on the right is one that shows that's been going on for a long time, and somebody might not notice that looking at it and say, well, the ball's lined up in the socket. But what you see here, this bone up here has this roundness to it that's the same roundness as the ball. And what that tells me is that every time this patient raised their arm up, this bone, the humerus, goes right up into this bone, which we call the acromion, and has been wearing out the underside of it. Well, that can only happen if there's no rotator cuff there. So that's another giveaway that something's happening there. And then here's another factor we can see on x-ray, which was talked about in the impingement syndrome, is you can get this spurring of the acromion. So you can see this bone spur, which many times is a calcification of a ligament that runs between these two bones. And sometimes people just have a natural curve to their acromion anyway. And so some of these x-ray views can help us see that. So beyond x-rays, if after going through the physical exam and everything, we are worried about a rotator cuff injury, I might get advanced imaging. I generally always order an MRI because I'm better at reading MRIs myself. We're not trained as much with reading ultrasounds. Ultrasound is something that's more read by the radiologist as they're doing it. And it's hard to get a good, and it's a dynamic test too, where they're looking and moving around. So that's a harder study for me, just to look at the individual pictures and get a good sense of what's going on, whereas an MRI gives me a good global view of all the soft tissues. That being said, there have been big studies comparing MRIs and ultrasounds to see if one is better than the other, and there really isn't, especially if you're looking for a full thickness rotator cuff tear, meaning the whole entire tendon is torn off the bone. MRI or ultrasound can be useful for either. So if there are reasons that a patient cannot get an MRI, I will order an ultrasound just to confirm a rotator cuff injury. And so what are we looking for? This is an MRI. Again, you'll notice the ball and the socket here. And you'll see kind of like those pictures that I showed, the rotator cuff muscle and the tendon that comes and attaches over here. A normal tendon is dark black through the whole entire tendon. Here you can see some gray and some white color through the tendon, which is a sign of usually chronic tendonitis, which we call tendinosis, and maybe even some partial thickness tearing. So when I say partial thickness versus full thickness, I'm talking about this is the thickness dimension of the tendon from top to bottom here. So a full thickness tear would mean none of this is attached to the bone, whereas partial, you can see there's maybe, it's not all the way black on the bone here, and that's maybe a partial tear. Here's a full thickness tear where the whole entire tendon is pulled off the bone. And when you see white here, that's usually fluid, which your body just fills a space which is supposed to have soft tissue, will fill it with fluid. And then I also look at some other slices of the MRI. It always makes slices in different directions. This is one where it's a cross section of the shoulder blade. This Y-shaped structure is the shoulder blade. And remember from those pictures we showed before, all the rotator cuff muscles start from the shoulder blade, and I can get a good sense of the quality of the muscle. So this is a very healthy quality rotator cuff. You know, people always say it looks like a side of beef, which essentially it is. It's a cut of muscle with maybe some small stripes of fat or tendon through it. And it's good and full. In this image, it's all good and full muscle. Whereas here you can see, as this one patient developed over time, that quality of the muscle really started to diminish and get smaller and fill in with anything that's white here is fat. It started to fill in with fat, which is what happens when muscles atrophy. And you can see down here, this muscle is atrophying too. That's caused by chronic tears of the rotator cuff. If the muscle is torn and it's not attached, the muscle can't continue to pull and get active. Think about if you ever had a cast on when you were a kid and your cast was on for 4 or 6 weeks and you took the cast off and the muscle was all small and atrophied because it wasn't doing anything. The same thing happens in the rotator cuff. The problem with that is once it starts to atrophy so much, then it gets to a point where potentially you can't repair it because the tendon quality and the muscle quality just isn't good enough to repair. So what is the natural history of these injuries, these rotator cuff injuries? And as I said, we'll go into some of the scientific studies that we use to make these decisions. This is one that was out of Washington University in St. Louis, probably from about 15 or so years ago. And the group there has a very strong shoulder and elbow group, and they did a lot of really good, big studies on rotator cuffs. They had a lot of funding from National Institute of Health, so they were able to get some really good kind of prolonged studies on the rotator cuff that really taught us a lot, and a lot of us used their data to help counsel patients. So this one, they just looked at the demographic and morphologic features of rotator cuff disease. So basically, they took patients who had shoulder pain and compared the shoulder that was painful to a shoulder that wasn't painful, and they would follow them up with ultrasounds and look at their rotator cuff. And some of the biggest findings from this was that the older the patients got, the more likely it was that they had rotator cuff tears. And once you got over the age of 66 and you had shoulder pain on one side, there was about a 50% chance that you had a rotator cuff tear on the other side and didn't even have pain with it. So this is something, that I always tell my patients, that unfortunately, the older we get, the more likely you are to have rotator cuff pathology, and that a lot of times you might have a rotator cuff tear and not even know it about half the time. Another study from Dr. Yamaguchi and his group in St. Louis, well, what about tears that get bigger with time? And this is something called tear progression. It's something I always counsel patients on, especially a younger patient, maybe somebody in their late 40s, early 50s, who has a small full thickness rotator cuff tear and maybe isn't even all that symptomatic from it, is that those small rotator cuff tears that really don't bother people all that much will probably become bigger with time. So they found that in 5 years, there was about a 50% chance that a tear that didn't bother somebody started bothering people. And that when that did, it usually meant that the tear got a little bigger. So what does that mean for you? So this is an analogy that I actually heard from a patient once that I think works really well. And I tell this to a lot of patients now. It's like tearing a phone book. So it's really hard to tear a phone book. Once you get it started a little bit though, then it's pretty easy to tear in half. So when you have a rotator cuff tear, if you have a small full thickness tear, there's a pretty good chance that that tear will get bigger with time. And depending on how old you are, what you want to do in life, what you want to get out of your shoulder, it might be beneficial to think about fixing it early. It's generally a little easier to fix early, and it's more reliable. You have a better chance of it healing well when it's smaller, rather than waiting for it to get bigger and then dealing with that problem down the road. So what are the different options when you have a rotator cuff tear? Certainly physical therapy is always the first option. Cortisone injections can be an option. I do them if needed. I don't push patients into them. I always kind of tell them the ups and downs of trying the cortisone injection. The one time I definitely shy away from them is if people do have those smaller tears that are maybe only mildly symptomatic, just to make sure, because it can mask pain. And if you have a small tear that you're worried about potentially getting bigger, you don't want to cover that up. You want the patient to know something's wrong with my shoulder. Again, I should go get this looked at. And then potentially, depending on the situation, surgical repair might be indicated. So what about physical therapy? Here's another study that a lot of us quote quite often. This was from a very big group, multi-center, so a lot of different doctors from different locations who came together and formed what they call the Moon Shoulder Group. So it's basically a big study group where they all lump their patients together so that they can get bigger numbers of people to try and answer some important questions. So they had about 450 patients in this study who had full thickness rotator cuff tears, and they were randomized, or not randomized, they were they were randomized to receive one of three options. They said, this is a different one. They were asked three different ways. So number one, did they feel that their rotator cuff or that their shoulder was fine? They were cured. They had no problems. Number two, would they like to continue physical therapy to see if the shoulder gets any better? Or number three, did they say, this isn't working for me, I want to consider surgery? So patients were followed up 6 weeks after they were first seen, then 12 weeks, and thereafter up to 2 years. At 2 years, 75% of the patients continued with non-operative care, and these are patients with full thickness rotator cuff tears. So this is something I always tell patients, especially if they have a smaller tear that maybe we're on the fence about really the benefit of an operation, is that 75% of the time, if they do a therapy program, they're probably going to feel better and not feel like they really need an operation. And that's usually between 6 and 12 weeks is when most of the patients made that decision. Conversely, 25% of the patients felt like it wasn't getting better and they wanted their rotator cuff fixed. And so this is useful information for us to know to counsel patients when they have these injuries. So what about the success of rotator cuff repair? This is an old study. This is from the early 90s. So this is getting to be 30 years old now, but I think the data is still pretty strong and it's been reaffirmed in many studies since then. This is from Dr. Mattson and his colleagues in Seattle, Washington. They had a 5-year follow-up on patients that they did rotator cuff repairs on. Overall, about 80% still were intact. They found that the re-tearing, so they would look at all these patients with ultrasound when they would come in for follow-up, were more common as patients got older, as well as the bigger tears. So the bigger your rotator cuff tear is, you have a higher risk of it tearing again down the road. However, even despite the fact that some of these patients had re-torn rotator cuffs, many of them were still satisfied and comfortable. So patients might have been, again, asymptomatic, had an ultrasound that showed their rotator cuff tore again, but it really didn't bother them, so there probably wasn't much to do about it. And so this, I think, is an important graph from here. These are the re-tear rates as through age groups. And you can see it goes up about 10% per each age group, which I think is always interesting. So what about another study looking at repair outcome? This is a randomized study. So this one, patients were either gone into physical therapy, in arthroscopic surgery where they just shaved down some bone spurs but didn't do anything to the rotator cuff and then given therapy. Or the third group, they had a rotator cuff repair. They did the shaving of the bone spur and therapy. They didn't find any significant difference, and their main outcome was a patient-reported outcome. So one of those surveys when you come into our office, that we use those for looking at outcomes in patients long-term. And so they didn't find a significant difference. However, they found that when they re-imaged all of their shoulders, those who had a rotator cuff repair overall had smaller tears. So again, some of them did re-tear, but not very big. Whereas the people who had maybe a small tear that didn't get it fixed are going to have a bigger tear down the road, that tear progression phenomenon again. And again, they looked at cost, and as you might expect, surgical treatment is more expensive. Again, another study comparing surgical management with conservative management. And again, we're talking mostly about chronic degenerative rotator cuff tears. And the patients were completely randomized to get surgical repair or to get physical therapy. They followed up with patients at 1 year. There was a difference, but not reaching statistical significance in terms of, again, those patient-reported outcomes. But if they took out the patients who retore, so this is a little bit different than the last study where the re-tears did make a difference, that as long as your rotator cuff didn't re-tear, you actually did better than somebody who did not have an operation for it. And as far as pain and disability scores, those were definitely better in the surgical group. So what's the bottom line? So again, I've kind of alluded to this throughout, but a lot of this is a conversation with patients about what they expect to get out of their shoulder, what their day-to-day is like, what they do for work, what they do for fun, what their hobbies are. We take all that into account, as well as other factors that are kind of irreversible, non-controllable: age, the size of the rotator cuff tear, and smoking status is a very big one as well. If you smoke, you have a really increased risk of re-tear or failure of surgical repair. So I kind of group people by this this stratification. So low risk of the tear getting bigger, and that's what we're really concerned about, a bigger tear in the future. So low risk is you don't have a full thickness tear. It's either tendonitis or a small partial tear. Definitely do not need an operation. You can do physical therapy. We can pretty safely do a cortisone injection to help control pain, and a large majority of these patients are going to become asymptomatic and get better. So high risk, meaning we worry about this rotator cuff tear getting bigger. So first of all, it's an acute tear. So you had a fall, you had a perfectly normally functioning shoulder, you fell, and now you have a full thickness rotator cuff tear. These are something you definitely want to consider getting an operation for. A symptomatic tear for somebody less than 60, again, I would strongly encourage that person to consider surgical management because of the risk of that tear getting bigger with time. A smaller, medium, full thickness tear of somebody in their 60s, or a high grade partial thickness tear that's really not getting better with non-operative management, these are more of a longer conversation about what you want to get out of your shoulder and what the ups and downs of surgery versus non-surgery are. But there's certainly times when we could consider surgical management. And then times when we're not as worried about the larger tear, irreversible changes have already occurred. So what I mean by that, those are those changes I showed on the MRI where the muscle has started to atrophy, the tendon is very much retracted. So these are times when the tendon is not even going to be repairable anyway. The cow is kind of already out of the barn, and we might have to start to talk about other options if it's something where you definitely feel like non-surgical treatment is not really working for you anymore. Symptomatic tears over 70, again, this is not a hard and fast age restriction, but in general, it's kind of, you're getting to a point where you're at a high risk of, even if we do fix it, the tendon may tear again. And again, the larger tears have a higher chance of re-tearing. So the bottom line, again, I use this graph a lot in my mind when I'm talking with patients and discussing what the ups and downs of surgery are. But again, age it's just a number. It's totally irrelevant except you're talking about a bottle of wine. Not totally true in this case. But once you get into your upper 60s, lower 70s, it does get to a point where we have to start to look at the quality of the tendon and the quality of the muscle and the size of the tear to try and figure out whether we think going through an operation and the recovery is going to be worthwhile. So what does going through the operation actually look like? So for me, most all of these are pretty much 100% of them are arthroscopic operations. So they're outpatients. I usually do them at a surgery center, so you're in and out the same day. This is kind of what things look like when you're all set up. You got all these drapes over you. You're sitting upright in what I call a beach chair positioner. And I have your shoulder exposed here. I use this is a camera, this arthroscope, and then use other little instruments through little tiny poke holes in the shoulder to then go in and repair the tendon. So this is a drawing of what a rotator cuff tear looks like. You can see the humeral head here and the tendon pulled back. And then this is what it looks like after it's repaired. So I usually use little anchors. They look like little plastic wall anchors almost. They get screwed into the bone. They have suture that's attached to them. And I pass this suture through the tendon, tie it down all arthroscopically, and then that repairs the tendon to the bone. So I always tell patients that's the easy part. It's outpatient, you're in and out the same day. Most patients get this operation done with a nerve block, meaning an anesthesiologist will numb your arm. You are asleep for the surgery too, but you also get that nerve block to help with pain control. That nerve block usually lasts for about 24 to 36 hours afterwards. And I give you some pain medicines to go home with. So that first 24 hours is generally not too bad because you can't really feel the shoulder. You were in and out of the surgery center. You don't have to spend the night in the hospital or anything like that. It's the recovery that is absolutely the toughest part with rotator cuff repair. And I never sugarcoat it for anybody. And I'm frequently told that I'm not a very good salesman for what I do, but I think it's more important that I'm honest with patients about what they should expect so that everyone really knows what we're getting into. So for my recovery, I generally break it up into 3 6-week blocks. So the first 6-week block is the immobilization. I'm sure seen people walking around with slings or immobilizers like this. And the point of this is, in this last picture I showed how we tie this down. That's basically like spot welding, or just temporarily holding the tendon into place. What has to happen is the tendon actually regrows into the bone. For the strongest fibers of the tendon to grow back into the bone, it takes about 3 months. That being said, I don't keep you in a sling for 3 months. Your shoulder would get so stiff that it would take us too long to try and get that stiffness back. But there is kind of the sweet spot we figured out around 6 weeks, where that's enough time for the tendon to start to grow back in, where we can then start passive stretches before we start working on active stretches, meaning the muscle pulling on it. So I usually have you in a sling for about 6 weeks. Towards the end of that 6 weeks, I have you start doing some gentle stretching exercises on your own at home, just to slowly get the shoulder moving and feeling a little better. We then, for the second 6-week block, transition to formal physical therapy most of the time. And that second block is all passive motion, meaning your therapist is doing stretches to get the shoulder moving. They're teaching you more stretches that you continue to do at home so that you can start to get more motion in the shoulder, so that hopefully by around 3 months, your passive motion, meaning if I lift it up or you lift it up with your other arm, is almost normal. And then the last block is building the strength back up, so that by this time the tendon is healed, we can start having the tendon pull more. So we start doing a lot of rubber band exercises and other strengthening exercises to get the shoulder feeling stronger. And that takes us to about 4.5 months. Some people need a little more PT after that to continue to work on some stretching and strengthening exercises, but that's generally the layout from there. As far as getting back to certain activities, it's definitely not usually until after that whole period of time. And anything that we return to is always progressive. So we don't just jump right back into, playing 18 holes of golf. You got to progressively work your way back up through your golf swing or whatever it might be. So what if you can't repair the tendon? That's unfortunately outside of the scope of this talk, and that would be a whole nother talk, couple talks actually on options that you do there. I just wanted to focus on rotator cuff injuries in general and what our mainstays of treatment are for them, as well as give you guys some of the data that we consider when going through this. So to summarize, majority of the rotator cuff tears that we see are degenerative rather than an acute full thickness rupture. The success of the repair really hinges on the ability to repair the tendon anatomically, restore that force couple, restore the way that rotator cuff functions in the shoulder to give your shoulder a normal function. And healing is really the biggest thing. We really need that tendon to heal. So we always have to play in the factors that we know have a lower chance of the tendon actually healing and becoming functional. And again, whether or not you're a candidate for surgery, it really takes in a lot of factors: pain, function, and what our expected outcomes are. So thank you.
Thank you, Dr. Davis. Great presentation. Again, if anyone needs to make an appointment with Dr. Davis, that VIP phone number is 610-480-6585. Again, 610-480-6585. If you have a few minutes, I'd love to go through some of these questions and answers.
Yeah.
The first one is, how can you increase blood flow non-invasively?
That's a great question, and one in which there are different types of research being done, but we don't have a good answer to. Some things you might have heard of are injections like platelet-rich plasma, which is PRP. What that is when you draw your own blood out, you spin out the red blood cells and you take the rest of the plasma and then inject it around the rotator cuff. Some people do that along with a rotator cuff repair. There's mixed evidence on what that actually really does for the repair. There's no evidence that suggests that it increases blood flow. There is some evidence that it brings some healing inflammatory factors to the tendon, but it's a little bit still up for debate. But as far as actually increasing blood flow, that the rotator cuff tendon is what is a natural, what we call watershed area. So there's some blood flow coming from the bone, there's some blood flow coming from the muscle, but right where it tears is usually an area where the blood flow is not naturally coming from that area. So it just tends to be a little weaker and not have the best blood supply.
Next question. If you have a partial tear, how can physical therapy help? Seems counterintuitive to doing this and may be at risk for more tearing.
No, physical therapy works very well for partial thickness tears. Again, it's all about keeping an eye on our symptoms, because those are that's the best tool that we have for knowing how your shoulder is functioning. And it depends on what type of partial tear it is. So we grade them depending on the thickness. So a high grade partial tear, we'll definitely watch that a lot more closely. And if it's not getting better with therapy, that will be one that I'm a little more pushed towards an operation to repair, so that it's not, so it doesn't progress to a full thickness tear. But a smaller partial tear, a vast majority of the time, one of my partners who I train with would tell every patient how he has a partial rotator cuff tear, and every time his shoulder bothers him, he just gets back on his bands, and the pain goes away. And so that's something that is tried and true. And as long as it's something that is, when you do the therapy, it gets better, and the pain isn't consistently staying there, then non-operative treatment is definitely the way to go. If it's something where it's not getting better with any of that, we would probably re-image to see if the tear did get bigger and then deal with it from there.
Okay. We have a lot of questions coming in, so I'll try and breeze through them real quick. Can you tell if there's a tear without an MRI?
So like you said before, ultrasound can be useful for identifying rotator cuff tears if for some reason somebody cannot get an MRI. A CT arthrogram, which is a CAT scan where the radiologist injects dye into the shoulder, and then we can see if the dye leaks outside of the shoulder joint at all, is another option. With a CT, those are more designed, a CT is like an advanced x-ray basically. So it's really good at giving us information about the bones. It's not as good at giving us information about the rotator cuff itself, although you can see the muscle a little bit. So that is an option, but it's not in quite as much detail as an MRI. So MRI is my preference. If somebody can't get it though, those are the options that we can do.
Okay, someone here is on prednisone. Can they do low weights for exercise, or is the prednisone just masking the pain?
Yeah, if you're on long-term prednisone, well, if it's a short-term prednisone, I would imagine maybe that was given for pain control. That will probably mask pain. Steroids do a great job of making all of our aches and pains feel better. So I would maybe end the course of that and then slowly begin a therapy program with weights and then see how things feel after that.
Okay. Can a small tear possibly heal itself over time?
So the tear, I didn't actually mention this, so that's a good question. Tears actually do not heal. So once the tendon pulls off the bone, there's nothing that brings that tendon back to the bone again. So once it's torn, it's torn. That doesn't mean that it's always symptomatic or that we always have to do something for it. So with time and therapy, it may become asymptomatic, but the tear is always going to be there. Even a partial tear, your tendon is just not going to be completely normal again. And so those are things that you just have to monitor and keep a close eye on.
Okay. You already touched on stem cell therapy, so I'm not going to ask that question.
Well, PRP is not stem cells.
Oh, I'm sorry. Yeah.
Different too. That's another biologic, and again, it falls under this umbrella that we call orthobiologics, which are using biologic treatments to try and heal. And that's definitely the future, and that's definitely where a lot of research is going, because that slide that I showed early on, the intrinsic versus extrinsic factors, biologic treatment definitely goes after those intrinsic factors. And those are the things we've identified that cause the tendon to be weaker. That being said, we don't have a truly proven biologic method that, you know, makes tendons heal better or really fixes the problem that we have with rotator cuff tears, but it's definitely something that's being worked on.
Okay. This person is 70 with a full tear. They're doing physical therapy. Will exercises be a permanent routine after physical therapy?
Yeah, probably. So I always tell people that you always want to keep in mind of those exercises you do at therapy. Really try and stick with your home exercise program consistently once you finish formal therapy, if it works. If the pain, if your symptoms are better from therapy, and you're able to do all the things that you want to be able to do, then yeah, you definitely want to stick with those home exercises, or at least keep in the back of your mind how to do them. And if the shoulder starts hurting again, get back on your bands and get back doing those exercises.
Okay. Could you explain the difference between bursitis and frozen shoulder?
Yeah, so bursitis falls in the spectrum of all this rotator cuff pathology that we talked about in this talk. So that area of the shoulder, I don't know if you guys can still see here. This area right here is called the subacromial bursa, and the area is the subacromial space, and there's a structure in there called the subacromial bursa. Bursa are little fluid-filled sacs that we have all over our bodies that help structures move smoothly against one another. And again, as I talked about the other names for rotator cuff pathology, impingement, bursitis is one that gets thrown a lot too. And basically that's when you see inflammation in that bursa, which could be from a symptomatic rotator cuff. It could be from this impingement theory. So that's just kind of in the spectrum of rotator cuff pathology. Frozen shoulders, a much different pathology. That's a pathology of the capsule, which underlies the rotator cuff. And that's where the capsule gets inflamed and stiff. And that's a whole different pathology with different treatment thought process.
After 5 months out, strength and flexibility are fine, but nocturnal pain challenging during sleep. Any ideas for age 71, massive repaired rotator cuff?
So that's a tough one. Sleep is definitely a problem with rotator cuff injuries, especially early on after repairs. A lot of the pain that people get when they're sleeping at night, I think, has to do with stiffness problems. So if you do have full range of motion, it might not be that as much of an issue. It could potentially be, a small re-tear, but if things are functioning well and not bothering you, it's hard to say. At 5 months, you could just continue with your exercises, give it more time. Usually if people by 6 months are still having a lot of issues, there's a lot of stiffness or a lot of pain, that's generally when I will re-image a rotator cuff repair to see if there's any loss of integrity to repair.
Okay. After shoulder surgery, this person re-injured. Is orthovisc or anything else possible instead of having a second surgery?
So orthovisc is what's called hyaluronic acid. It's one of the molecules that's in our joint fluid. That was designed as a treatment for patients with arthritis, with the theory being that it kind of reinstates some of this normal joint fluid to help with pain. It's used in the knees a lot for arthritic knees. It is not approved for any use within the shoulder by the FDA because there hasn't been any good evidence that it shows that it does anything to the shoulder. And again, that's for shoulder arthritis. So that's a different pathology than we're talking about here. So if you have a retorn rotator cuff, I definitely don't think orthovisc is, first of all, it hasn't been studied to prove anything, and second of all, it's not going to get paid for by an insurance company because it's not FDA approved for the shoulder. So it all depends on your symptoms, on how you're doing. If it's something that's causing you a lot of problems and pain and weakness, it certainly could be something to look into for further treatment or another operation. Again, that would be something where I would need to have more of the details in the specific case.
If physical therapy is an option to surgery, how does it help heal the shoulder?
Sorry, say that again. If
If
PT,
physical therapy is an option to surgery, how does it help heal the shoulder?
by strengthening all the other muscles around the shoulder. So the shoulder blade, the shoulder joint is pretty interesting, I think, obviously, because I'm a shoulder surgeon. But one of the things that's interesting about it is, as far as a bony connection to your axial skeleton, which is your spine and your rib cage, the only bony right here, where your collarbone has a joint with the acromion, the end of your shoulder blade. The rest of this is all kind of muscles holding the shoulder blade. So the shoulder blade is kind of like a floating structure, which then makes the shoulder kind of this floating structure. So there are 14 different muscles that attach to the shoulder blade at different points. My point of going through all of this is that the reason therapy can be so helpful in the shoulder is retraining where that shoulder blade sits and how the shoulder joint itself functions can be really helpful. And so if you have a partial tear, that can throw off a lot of these other mechanics around the shoulder that therapy can help to retrain so that the shoulder isn't as painful for you. So it's different than where you have a tear that's throwing off those mechanics, and the goal of the surgery is to repair the tear to restore that normal function. If it's a partial tear, it's something where therapy can be helpful by retraining and strengthening all of these other muscles around the shoulder.
Okay. Is there a difference between a rotator cuff tear and a rotator cuff injury?
Yeah, I mean, a tear is something that I would say is on the spectrum of rotator cuff injury.
Okay. How do you handle a calcium deposit for a 70-year-old?
So calcium deposits are interesting. They are also in that spectrum of rotator cuff injuries. What a calcium deposit is usually caused by is chronic tendinitis within the tendon, where our bodies sometimes lay down calcium in that area to try and stabilize or heal whatever is irritated in the tendon. They can cause problems because I would say this is like having a pebble in your shoe. So a calcium deposit usually lives right in this spot around these tendons, and as you move the shoulder around, it can cause really impingement where the tendon's supposed to be nice and soft. You have this firmer piece of calcium. Many times the calcium deposit goes away with time, so that's one option, just giving it time. Cortisone injections, I think, are only so-so because it's usually a mechanical problem, meaning it's not an inflammatory, it's not that the tissues are inflamed, it's that there's an actual firm piece of tendon that's causing the pain. I've actually been sending a lot of my patients to one of my non-operative partners who does a procedure, so it's not a full surgery, where they can go in with a needle and actually break apart the calcium deposits and suck them out. And he's had a lot of success with patients dealing with that. So that's something that we've been working on as well.
Okay. How do you integrate diet and nutrition to reduce inflammation?
So that's a good question that a lot of people have a lot of different opinions on. I certainly think that there is a role to be played, and I think it has to do a lot with what people's current diets are and what they've used. There are certain natural supplements like turmeric or things like that that can help decrease inflammation. I don't make a lot of nutrition specific advice, but I do think for sure that nutrition plays a role in like our global inflammatory status, basically.
How about CBD effective for healing?
I think it's certainly something that's worthwhile to try. I think the topical treatments for aches and pains, I've definitely had patients have very good results. I've had some patients that say it didn't really do much at all. I think that the safety of it is pretty stable. I don't think that there's been any evidence of a lot of harm or issues from using it. So I would definitely say if people would like to try it, I think it's a safe thing to be able to try. That I've in my anecdotal experience with patients has had 50-50 success.
Okay. As we age, with no rotator cuff issues, how do we keep it that way? Will regular exercise help maintain the quality?
Yeah, definitely. I think regular, maintenance type exercises where you're doing, low rep, low weight, high repetition, safe exercises. So, and some positions to really focus on. So, you don't want, if you're doing anything overhead, you don't want your arms back behind you, the plane of your body like this. That's going to be bad for your shoulders. So, your shoulder blade sits on your body about 20 degrees angled in this direction, kind of like this. So I say any overhead exercise you do, you want your arms to be in the plane of your shoulder blades while you're doing them. You also don't want to be way down low like this when you start up with resistance. That can be pretty tough on your shoulders. So any overhead type of press, you want to be in front of you and you want to kind of just stop right here before you go back up. And then if you're doing any pushing exercises, bench press, push-ups, anything like that, always imagine that you're doing them on the floor, so that when you come down, your arms stop here. Again, you don't want to come back like this. That's going to be really tough on your shoulder. So you just stop here and then push forward. The wider that you are, the more stressful it is on your shoulder. The closer in you are, the safer it is. So I think doing exercises and keeping that in mind is going to lower your chance of a shoulder injury.
Okay. What other common issues can possibly be causing mild pain in the shoulder if tears are eliminated?
There's a few things. You can have biceps pain, labral issues, arthritis, capsule issues like frozen shoulder we talked about before. Those are kind of the big hitters that cause the most problems for people.
Okay. Someone on here actually lives in South Jersey. Is there someone in Cherry Hill you would recommend at Rothman?
Yeah, Luke Austin, one of my partners. He's fantastic.
Okay. All righty. That looks like we got most of them.
All right.
So again, thank you all for attending. I will be sending this presentation out, the recording of it, probably by the end of the day or tomorrow. So keep an eye out for that. If you have any other questions or need to make an appointment, you can call the VIP line. You'll have my email address. You can reach out to me directly. So, all right. Thank you so much. And thank you, Dr. Davis, for taking the time to be here.
Yeah, absolutely. Thanks, Casey.
Thank you.